Module 6, Infusion Therapies. So we're going to talk about different solutions used in infusion therapy. Remember that these are all medications, even normal saline, and we do need a doctor's order to administer these. So we're starting off with crystalloids. So crystalloids are composed of electrolytes dissolved in water. They are low molecular weight salts or sugars, so this includes dextrose. They are completely dissolved in that water, and they're able to pass freely through the intravascular and interstitial space. These do pose a risk if you give too much fluid that it can cause edema because they do pass through the intravascular and interstitial space. And these will remain in the vessels or vascular space for a short amount of time. So this is going to include dextrose solutions, which is glucose, sodium chloride solutions, balanced electrolyte solutions, alkalizing and acidifying solutions. So some examples of crystalloids are NS, LR, 3% sodium chloride, and plasmolite. So crystalloids are much cheaper and easier to manufacture than colloids, which is the next type of solution that we're going to talk about. So here you have a picture of LR, you have 0.3, or I'm sorry, 9% dextrose injection, 3% sodium chloride injection, and this one is plasmolite. So plasmolite is an engineered solution that is actually the most closest to our plasma makeup in our body. So this one is actually very, very similar to our plasma. So you may ask, why not use plasmolite for everybody if it's the most, similar to our plasma? That is because this has lots of electrolytes in it and it has sugar in it, and not everybody needs that in the hospital. So for example, if you have a problem with potassium, say you have hyperkalemia, but you also need fluids, then plasmolite would not be a suitable option because plasmolite has potassium in it. Okay, so it really just depends on the patient's condition. All of these solutions have a purpose, and we shouldn't just give one without knowing why we're giving it. Next, we have colloids. So colloids have these big protein or starch molecules that are suspended in fluid, so they're not completely dissolved in the water, and technically they're not a true solution. So these do not pass freely through that intravascular and interstitial compartments. They will stay in the vascular space, so in the vessels, which is why we can use them as plasma volume expanders. So these are used to maintain intravascular volume and to prevent shock, especially after major blood loss. So if you have a patient who lost a lot of fluid really quickly, then they would benefit from a colloid. You have to also be careful with colloids because they don't leave that intravascular space that easily. So if you give too much, they can become hypervolemic. They can have fluid overload. But in emergency situations, they're very effective. So these type of medications, the dextran and the mannitol, will be administered in ICU in a controlled intensive care unit. Albumin is considered a colloid, and that one we can infuse on the regular Med-Surg floor, on a telemetry floor. And as if you remember before, albumin helps to draw fluids back into the intravascular space. So this can help if a patient is very, very hypotensive, which is what happens in shock. Okay, you become very hypotensive. Another review on osmolarity and osmolality. We're going to use these interchangeably. Just a recap, osmolarity is referring to the number of particles in a liter. Osmolality is the number of particles in a kilogram. But a liter weighs about a kilogram, so these are interchangeable. So let's talk about our blood plasma in a normal human body. So we draw our blood, and if we put it in a tube and then put it in a centrifuge and spin it, all of the contents will separate into layers. We're going to have a plasma layer, a buffy coat, and a erythrocyte layer. So that plasma is what we are looking at here. And if you looked at it under a microscope, you're going to see lots of stuff in there. You're going to see lots of sodium, glucose, urea, which is a waste product, potassium, magnesium, calcium, and proteins, and some other electrolytes in very small amounts. So the IV solutions that we are going to give the patient, the concentration of those solutions is going to influence how the water moves between that intracellular and extracellular space in the body. And we're going to call these solutions either isotonic, hypotonic, or hypertonic. And this is going to be based all on concentration. So isotonic, here's the range for that. Hypo, less than 250, hyper, 375 milliosmoles per liter. So we're going to start with isotonic solutions. So a very good example we're all familiar with is normal saline, which is 0.9 sodium chloride. In it, it has sodium and chloride, just those two electrolytes, and they're equally dispersed. There's 154 MEQs of sodium and 154 MEQs of chloride, equaling 308 MEQs. Lactated ringers has different ingredients, but it is still isotonic, 274. If you look here, our normal plasma is 370 to 300. Isotonic solutions are between 250 and 375. Okay, and we're talking about concentration. Now, when would you give one or the other? We're going to talk about that. But like that example I gave before, lactated ringers, it has other stuff in here. So if the patient is already having an issue with calcium or potassium, then we're not going to want to give LR. Okay, same thing with sodium chloride. If the patient has too much chloride already, like maybe they're in acidosis, then maybe this might not be the first option we give. So isotonic solutions cause no movement of fluid into or out of the cells. Okay, so the cell is pretty much going to stay the same shape. There's not really going to be any fluid moving in and out. This is a good solution to give when you're trying to replace intravascular volume. So say you're dehydrated, you lost fluid, all you need is fluid replacement, then an isotonic solution would be appropriate. So here's our patient here, hot in the sun, sweating a lot, losing a lot of fluid, hasn't drank anything, dehydrated. This is what a normal vessel will look like, and here's our dehydrated patient. The contents inside have stayed the same, it's just that the fluid volume, that plasma, has decreased. So this patient needs replacement of that intravascular volume. So we're going to give an isotonic solution. Now we're talking just generally speaking because we don't know anything else about the patient. We don't know what electrolyte imbalances they do or don't have. So these are another list of isotonic solutions. So NS, 0.9 sodium chloride, lactated ringers, 5% dextrose in water, and 5% dextrose and 0.225 saline. These are just some examples. There are a few more. So 5% dextrose in water, we say D5W for that. So this is water, right? H2O, 2 hydrogens and oxygen plus 5% dextrose. This doesn't have any electrolytes in it. And once that dextrose goes into the body, our body is going to use it as energy. So that glucose is going to leave, and it's just going to leave water eventually. So it will be considered a hypotonic solution after that process. So we just want to keep that in mind. As we go on, you're going to find out why this is important in some patients. Hypotonic solutions. So anything that is not iso, it has less solutes than isotonic, is going to be hypotonic. So normal saline is 0.9%. Here we have 0.45 sodium chloride. This is less than 0.9. This is half NS. We can say half NS, we can say NaCl. It all means 0.45 sodium chloride. And in this solution, you can see we have 77 MEQs of both sodium and chloride equals 154, and it falls within our range here as a hypotonic solution of less than 250. We have a third NS here, 0.33%. This has 56 and 56 to equal 112. Again, hypotonic solution. So we're going to give a hypotonic solution when we want fluid to move into the cell. And this is going to be hydrating. So sometimes those cells are dehydrated and shriveled up. So we would want to rehydrate with a hypotonic solution. Some situations where this would happen would be hypernatremia, diabetic ketoacidosis. We're not going to get too into these conditions, but there are some conditions where the cell starts to shrivel up and we need to hydrate them. We want to be really careful when we're using anything but isotonic. I mean, we have to be careful with isotonic too, but if we start using hypotonic or hypertonic solutions, there's going to be fluid shifts, and we need to be aware of what those fluid shifts are, and we should only be using the solutions temporarily for short-term use only. In this picture, you see a big round hippo. That's because hypotonic solutions make the cells plump up and look like hippos, okay? So here we have some shriveled up dehydrated cells. So the cells have lost a lot of fluid and now they're all shriveled up. So we want to put water into the cell, so we are going to give the patient hypotonic solution. Here are some: half NS, a quarter NS, and a third NS. So what we want to be very careful with hypotonic solutions is hypotension. So here we have our cells, and let me change my color here. I'm going to use blue. So this is fluid, right? Because these cells are in plasma floating around. And then we're going to introduce a hypotonic solution. So all of this fluid is going to enter the cell, which is what we want because they're dehydrated. But what's going to happen to all of this fluid out here? It's all going to enter the cell. Because remember, more than 60% of our body fluid is inside the cell. So the cells have space. The cells have a lot of space to take up fluid. So it's going to leave not a lot of fluid left outside of the cell. And if you don't have a lot of fluid, you're going to become hypovolemic and you will have a low blood pressure. So with patients who already have low blood pressure before any of this, before we even give them a fluid, then we may not want to give it, because if we give this fluid when they're already hypotensive, then it's going to make it worse. It's going to cause an even more of a drop in their blood pressure. So we want to be careful. Again, these patients on these types of solutions, it's very short term. You're not going to see a patient on half NS for a week because it's going to cause too much fluid shifting. And once we achieve the goal, then we stop that type of solution. Next is hypertonic solutions. This is going to be anything more than 0.9% sodium chloride. So here we have 3%, so that's definitely high. And look how much it equals to 1,026. So definitely hypertonic, very, very concentrated. 5% dextrose in LR is also hypertonic. You remember LR is isotonic, so if you're adding a bunch of glucose, dextrose in it, it's definitely going to become super concentrated. So hypertonic solutions are going to do the opposite of hypotonic solutions. They're going to cause fluids to move from the cells, out of the cells, into the intravascular space. This can cause the opposite of hypotonic solutions, because remember, with hypotonic, we can cause hypotension because we're pulling all of that fluid into the cell. But with hypertonic, we're pulling all of the fluid out of the cell, and all of that fluid is going to go into the intravascular space, into the vessels, which can actually cause circulatory overload or hypervolemia. So again, you want to be really careful when you're administering hypertonic solutions or hypotonic solutions. So here we have these really big overfilled cells. This can happen with pulmonary edema and some types of fluid overload. So if we want to pull that water out of the cell, we are going to give a hypertonic solution. So if we have a hypertonic solution, we'll just say it's salty. Okay, it's really concentrated, it's really salty, and inside here, it's very dilute. So when it's really salty out here, all these little particles out here, the body wants to make it even. So that hypertonic solution is going to draw the fluid out of the cell to make the outside area less concentrated. So that's what's happening. So these are examples of hypertonic solutions. Down here we have 3% saline, 5% saline, 10% dextrose in water, D10W, 5% dextrose in NS, 5% dextrose in half NS, and 5% dextrose in LR. So the more concentrated you get of a solution, you want to consider using a central line to give it to the patient. If you were to use a really, really, really concentrated solution in a regular IV peripheral vein, those veins are going to become injured. So we don't want to do that. We don't want to, injure our veins. So we need a very large vein, like through a central line straight to the heart. Again, we don't use these very often. It's only in specific scenarios. This is what real cells under the microscope look like. So the first one, this is red blood cells in an isotonic solution. They look normal. They look how they're supposed to look. Then the next picture, they were introduced to a hypertonic solution, so very, very concentrated solution, and it sucked all of the fluid right out of the cells, and now they're shriveled up. The red blood cells were then placed in a hypotonic solution, and all of that water filled the cell, and now they're very plump. As you can see, they lost that little divot that they should have, like in this picture on the left. So our IV solutions generally are slightly acidic, which is on purpose so that they can be stored. And, they all have expiration dates, but if you look, they're usually like a year later. Medications, of course, less than 7 are acidic, greater than 7 are basic or alkaline. And fluids or medications with a pH of less than 5 or greater than 9 need to be given through a central line. We want to make sure that we check compatibility of our medications. Sometimes we don't know why they're not compatible. We just know they're not compatible, but that could be related to the pH of the solutions that you're using, and it can make the medication less effective. So antibiotics are also really common to cause damage to the veins or phlebitis because they're typically lower in pH. Okay, so what do we need to know from this section? What's the difference between crystalloid and colloid solutions? So crystalloid solutions, they're cheaper, they're more common, right? They don't necessarily stay in the intravascular space for that long. Colloid, more expensive. They're usually in a controlled setting like the ICU, except for albumin, and they stay in the intravascular space for a long time. We have to be really careful with those. How does isotonic fluid shift in and out of the cell? Well, isotonic is kind of like our plasma, so it really doesn't cause fluid shifts. Hypotonic fluid, well, hypotonic is going to cause fluid to enter the cell. Hypertonic fluid is going to cause the fluid to leave the cell. You want to give examples of each type of fluid and just give a situation where it's appropriate to administer each of those, which the example is given on each of those slides for you to review. Okay, and that concludes this chapter.